I want to thank Dr. Nanda for joining us. Those of you, I'm sure most of you know who he is, but I'll introduce him anyway. He's the head of the Department of Craniofacial Sciences and the chair of the Division of Orthodontics at the University of Connecticut School of Dental Medicine. The current editor-in-chief of Progress in Orthodontics. He was the Angle lecturer this year at the AAO, and if you missed his talk on Friday, I'm sure that you can see the replay via the AAO. They record all those things too. And of course, he's been in JCO numerous times over the years, a particular focus on biomechanics. And we've been honored to have him on our editorial board. So Dr. Nanda, thanks for joining us.
Thank you, Phil. It's a great pleasure to be here. And I was moving around to adjust my chair because I am in Bend, Oregon, at Brasada Ranch. And I was trying to figure out where it would be the best lighting. So I found it on this kitchen table, so.
Excuse me. Yeah, no, you look great. So again, for those joining us, any questions for Dr. Nanda, you can put them in the chat and we will read them off of there. While people are thinking, I think a great place to start, of course, is you not only have expertise in biomechanics, but you also have expertise in, well, in many areas, of course, but headgear also was something that I was looking back through an interview we did with you a few years ago, which people can find in our archive. And one thing we've noticed, of course, is a long-term trend in our diagnosis and treatment studies is that headgear has sort of declined in use pretty regularly, although it's kind of leveled off at this point. We do that study every 6 years, so it's sort of long-term trends, with essentially facial masks being the lone exception. So what do you see here in 2021 as the role of headgear in treatment, especially including protraction in orthodontics?
Well, the headgear use declined primarily because of patient compliance and also the results were not very evident on a regular basis. Like a patient comes in and the molar is not moving back and you are blaming the patient that the patient is not wearing the headgear, or you are using headgear at the wrong time for the growth modification purposes, because the idea was that headgear will keep the maxillary growth in its place and the mandible will catch up. Later on, we found that a lot of class 2 patients were because of the problems with the maxilla rather than the mandible. So, and then in the meantime, a lot of other non-compliant appliances came into the market, starting with the pendulum appliance and, Jones jig. And so we went through that phase. So the headgear use sort of went away, like people started using Forces appliance to do the same sort of, not same sort of thing, but sort of a little bit differently. So the headgear use sort of went away, and now we are using TADs, and TADs are doing a lot of that function. So the only thing is that headgear use was there for a long period of time, and we were looking for growth modification. And all these non-compliant appliances have a lot of side effects other than if we get any growth advantage.
Yeah. It always is interesting looking at that. We talked about the treatment study yesterday with Dr. Graham in terms of accelerated orthodontics, because accelerated is another one where as we watch these long-term trends that it was kind of going like this and then it just plateaued and it never took off to really any large degree. And it was interesting because Dr. Graham, who, as you know, is our hot seat editor. We had a hot seat on accelerated orthodontics a few years ago. And he, at the time, in that hot seat, was using accelerated more than he does now. So he's part of that sort of leveling off or dropping of the trend. And he was saying yesterday is sort of a case of the evidence not really being there for a lot of the methods in terms of it actually, in a significant way, getting the treatment times shorter. Headgear is kind of on the opposite end. Of course, it's longer. I had headgear when I was a youth.
I think it did a good job on you.
Yes, yes. And so that was much more of that phase one longer term kind of treatment than accelerated at the opposite end. And another thing we talked about is, so the other end of that is aligner therapy, right? So if accelerated kind of just went like this, aligner therapy has just exploded.
Sure.
And we just had an issue on doing complex cases with aligner therapy in January. Where do you see that fitting in, I guess, especially from a biomechanical point of view, as we're getting into more and more complex uses of clear aligners?
Yeah, let me first say a little bit about accelerated orthodontics. We got involved with accelerated orthodontics very, very early because we were approached by Excellent to do some research before they brought the product in the market. And they gave us a lot of money to do this research, and the net result was we did not find any acceleration at all. And they were pretty mad at us for publishing that article because they said, please don't publish it. I said, no, we have to. So we published 3 articles in where we said, gee, Excellent, like the concept of vibration is not working, okay? But the problem in orthodontics is that clinicians jump at anything which new comes along and there is no evidence-based data on it at all, okay? So the key opinion leaders come into the pictures and suddenly people start giving talks that it works for me and works for me. Excellent was a perfect example that in the end, everyone realized that this darn thing doesn't work at all, okay? So the same thing comes in with micro osteoperforations, which I listened to Dr. Graham's presentation yesterday. And we are coming to that conclusion too. Now clinicians and all the studies which are coming out, that all these appliances like, you put a little screw in. I mean, it may do it, accelerate for maybe 2 weeks, but the treatment is going to take 18 months, 12 months. So what are you going to do every time patient comes in and you're going to drill a hole in the bone? So now we are realizing that's not going to work either. So that's my comment about that. We kind of jump very fast and then we jump off the train, right away, and as far as the aligners are concerned, I gave in my talk a little bit about that more and more studies are coming out that where we can use aligners for complex cases. For example, I work very closely with Kenji Ojima. Now, in his practice, where I've been now many times, he's doing cases which we will not even imagine doing in, at least when I was actively practicing that. Oh, wait, no way we can do it. But he does it. But he does it because he does not accept the clinic as it comes along. He kind of devises his own treatment plan rather than remotely somebody's trying to tell him.
Right.
And then he's also using elastics, he's using tags, and sometimes he's going to use brackets. So it's not like I'm completely wedded to one way of doing it. What is best available for me and to do that? So I think we can do complex cases with aligners. But the problem, especially in US, is that we are a little bit complacent about, we have no time, we are very busy, our practices, we may see 100 patients a day. People have no time to sit there and work on each and every case, what is going on. And the net result is that you end up with 60 trays right away. And then you don't know that by the 35th tray or 30th tray, if it's going to work in the mouth or not, So there are some issues there, you know. I mean, I'm never in favor of getting all the 60 trays coming to you right away, because in complex cases, things are going to move a little bit differently, because you may have to change your treatment plan. You are working maybe with interdisciplinary people. You are working with surgeons. You are working with prosthodontists. So it may be, we have to devise a new way of doing it. In other words, maybe 10, 15 aligners, and then you kind of scan again and you send it. I think in future, we are going to be doing more and more aligners. And, you know, it is a little bit strange coming out of my mouth, because when Invisalign came 22 years ago, we always said in education, it's going to go away, you know, it's just a fad. And now here we are, you know, the times are changing.
Yeah, for sure.
Yeah.
And so I guess one thing that will go along with that is probably the more complex the case. I know that we know this from our treatment study, that some orthodontists go quite a bit of time between appointments for aligners. So probably the more complex the case, the more you want to get them in to see what's going on.
Yeah.
Even as you're switching trays out, obviously, but maybe not go the 8-10 weeks between appointments.
The other issue with aligners is that the sort of technology was dumped on us. In other words, you know, here's an aligner and it's going to close spaces, it's going to open up the spaces, but nobody talked about biomechanics, you know, how the teeth are going to move, what are the side effects are going to be. That only just started, you know. So from my viewpoint, we are still in infancy stage of aligners, because we really don't understand the plastic deformation. We don't understand what thickness is the best. How many, you know, I reported on one study 2 days back in which they looked at thickness of 0.2, 0.4, 0.6, 0.8 of aligners. And if you do the deformation of, let's say, 0.2 with a certain thickness, you will see you start with a force of maybe 10 Newton, and within like 3 days, it's down to 2, you know. So it dissipates very fast, you know. So we have to figure it out how the force delivery is going to be with aligners.
And would the patient's tendency or not lack of tendency toward grinding their teeth also affect that thickness if you got aligners on both upper and lower? You know,
yeah, I think thickness probably has more to do with the stiffness. Thicker the aligner, the stiffer it is, and more difficult it is to put it into the mouth.
Right.
Okay. So we are using a lot of attachments now, and when you have attachments and you use a thicker one, you just can't put it in the mouth. And sometimes we advocate that maybe the thickness of a liner should change from beginning as you go along, because you may need a thinner aligner in the beginning when you're starting the tooth movement, but the initiation of the tooth movement has already taken place. Then you can go ahead and use a little bit stiffer, because teeth are already mobile, you know.
So a similar kind of thought process like with wires, where you're...
Exactly. That's where it's coming from.
Yeah. Just to interject here for those who weren't with us at the beginning here, any questions you have for Dr. Nanda, please put them in the chat. We'll read them off of there. We're not going to unmute and do anything like that or raise your hand. Just type it in the chat. We'll see it, and we will answer it on any topic. Doesn't have to be what we're talking about. Feel free to, if there's anything that you want to chime in on. So when it comes to biomechanics, since we have you here, what do you think, and obviously this is a very general question, but in terms of orthodontists today, what do you think is least understood about biomechanics and their role in you know, like in an everyday kind of practice way?
I think the least understood is the side effects Okay.
Mhm.
We continue to use appliances, the wires, and we don't know what the side effect this is creating. Net is example is that you may be using something to move the molar back, but then you're finding you're flaring the lower incisors, and that was not your treatment plan. And so the same thing is with the space closure, that you are trying to close the space by bringing the anterior teeth back and the molars go forward. A good example is that you will often hear that especially from certain sections, a lot of times it's coming from the GP side, general practitioner side, that with extraction, orthodontists flatten the faces, and that is a side effect, because if you have extracted in a patient, you have to look at the patient's profile. And you may find that you extracted just to relieve the crowding and you don't want to move the incisors back and you want to bring the posterior teeth forward. So that's where biomechanics come into the picture, because now you have to apply a force system which will keep the front teeth where they are and would bring the posteriors forward. So extractions have nothing to do with flattening a face. When somebody asks me that question, I always say, then you're doing something wrong with your patients, And that's where the tags come into the picture these days, because suddenly you have an anchorage and you move teeth where they should go. But a lot of times in orthodontics, we are so busy, we are so busy. We extract, we put elastics on, teeth are moving, fronts are coming back ones are going forward, and suddenly, since the front teeth are much smaller, move faster, and you have so-called dished-in face, So that's a good example of biomechanics.
And is that sort of, the real advantage that orthodontists need to push over GPs and do-it-yourself outfits, that the orthodontists are at least supposed to understand the biomechanics of teeth movement, really, to a degree, much beyond any GP would, and that if you're going to get your teeth treated, that's why you see an orthodontist.
And that is where you are going to differentiate yourself from the GPs and do-it-yourself kind of situations, or people who are mailing you the stuff at home, So I think biomechanics the knowledge of growth and development, the biological aspects that's where we are differentiated from uneducated, I would call, in orthodontics.
Right. And beyond what obviously you learn in schools like yours and other ones, of reputable ones around the country, what should people be doing to enhance their knowledge of biomechanics to differentiate themselves in that way?
I think people have to ask a question, that why you are using a certain appliance, okay? So for example, if you're going to go out and pay $250 to buy a little gizmo where the patient has to put an elastic in the mouth, there's something is wrong with you, because what are you doing there? You're trying to correct a class 2 by bringing the lower teeth forward, steepening the occlusal plane, flaring the lower teeth. Upper teeth are not going to go back, they're going to tip back. So example is that if you know where the center of resistance of the teeth is, and you are applying a force below it, you are not translating the teeth, So the molar is going to tip back, molar is going to upright. How does molar upright? The crown is going to come back and the patient is back into class 2. So what I always say is that you have to realize what you are doing and what you are expecting. This is why I always say a simple example. For example, if you want to tip the molar back, you put a little cantilever with beta titanium wire, cut the molar from the arch wire, and just hook the cantilever there with about 25, 30 grams of force. You got the same thing what you're going to get with $300 appliance. So anytime you want to use something, you've got to know what is the simplest possible way I can treat that. And I mean, example is forces or similar devices, which I published several papers on twin force bite corrector and all that. We were able to get perfect class 1 molar relationship. But the net result was that if we started lower incisor at 93, it was almost 99 or 100 at the end of the treatment. We tried our best to stop it, but we could not. So if that is your objective, then it's fine. But you should tell the patient, hey, I'm using an appliance which is going to flare your lower teeth and your lip's going to go a little bit like this. It's fine. But we don't tell them because in a way we don't want to spend too much time on our patients. And these appliances just help us. Same thing, aligners. Why are aligners popular? You give patient 2 or 3 sets at a time. Patient comes in, you open the mouth, everything looks good. I'll see you next time.
Yeah. So
same thing is with using these non-compliant appliances too in the mouth.
Yeah. The aligners, of course, also are popular people because it's invisible, right? So that's why patients love them.
Yeah, but not truly, because my wife is having Invisalign, I think, second or third time, but she hates those attachments. So there's a wedding coming up, and she's going down to her orthodontist, Dr. Bradford, in Jupiter. Can you please take these out, because at this wedding I don't want my smile to show these attachments in the front.
Right.
So it's the same thing. Patients used to come to us, oh, can you please take the braces off and put them back again?
Right. Yeah. But it's interesting what you're talking about with the thinking ahead. It's sort of what we do with our Student of the Year competition. Part of it is we Dr. Sinclair provides us with some kind of nasty case from his office, and we give it to the residents, and they're supposed to give us a treatment plan. But part of what we specifically are looking for that from them is a description of what could go wrong in their treatment plan, and if that happens, what they would do to mitigate it. And that's sort of what you're saying, if I can put words in your mouth, is that's sort of the approach you should take with all your patients, with every treatment plan you do for any patient, is to think about the biomechanics of what you're doing in terms of what could go wrong and what you would need to do if that happened, or when that happens, depending on what you're doing. Exactly. So again, any questions, you can just put them in the chat. We have a couple minutes left here. When it comes to we briefly touched on the sort of orthodontic side of how you differentiate yourself. How do you sell that to the public? So how do we, as orthodontists, get the public to understand, or this could include rules for the AAO and for publications like ours, JCO, to get the public to understand that key difference we talked about from general practitioners to orthodontists, to get people to use orthodontists.
This has been $1 million question for a long time. 50 years back, and I'm going back 50 years, the number one problem in orthodontics was too many GPs were doing orthodontics. Okay. Yep. 40 years back, it was the same problem. 30 years back, it was the same problem. One of my graduate students did a study where we had 2 organizations which cater to GPs, American Association, I think it's AOS they call it, and one was International Association. We sent the questionnaire to them. There were about 30 questions in there, that how many patients you do and all that. And we had a fantastic response, about maybe 600-700. So we wrote that paper with some folks at UConn, We sent it to AJO, and they rejected it, I think 2 or 3 times, because their attorney said, it's not a good, it's not going to be a good one for the journal somehow, because we had asked certain questions and they said there may be an issue with why. And that study basically showed that a typical general dentist did not start more than 10 cases a year. They were fixed appliances at that time. So there was all the time this thing, GPs are doing so many cases and we are not getting cases in our practice, Now
Right.
the situation is completely changed because with aligners, I mean, anytime I go to a dentist or visit him or see him in his office, there's this, we do this, we do that.
Mine has one too.
It's totally changed.
Yeah. So you think that we've sort of been crying wolf about this for a while, but now it's sort of a real concern about dentists doing.
But we have accepted.
Yeah.
You don't hear much about it. I mean, people will say that Invisalign a company is creating problem by pushing that towards the general dentist. But we are not now talking anymore about, general dentists are doing. Right. I mean, we may be complaining, but that's the way it is.
Yeah, I mean, you saw it yesterday, of course. If you watched it, Dr. Graham's view on that was that actually the Invisalign and the like are helping us by creating more demand out there. Yes. Where it didn't exist before for orthodontics, people who wouldn't have gotten it. I mean, mostly adults, obviously, in that case.
He's 100% correct. We see people are coming second and third time for orthodontics. They had them at the age of 12 years. Some had corrections in 20s, and now they come to us at 40s and 50s. Okay. Yeah. So I just bought a new house in Florida, and the lady who sold us, 69 years old, and she said, "What do you do?" When I met her the first time, I'm an orthodontist. "Oh, I want aligners, Invisalign." I said, "Why don't you go to Dr. Bradford? He'll give you." Dr. Bradford calls me the next day and says, "Can you believe you send me this patient?" She signed the contract right then and there. So just look at it, 69-year-old going down to get aligners.
Right.
Mild crowding in the lower, that's all.
Yeah. Yeah, and they're great for that, obviously. My wife is getting aligners for exactly that, minor crowding.
We'll figure that.
Yeah. Yeah. So, we also, I think, so you see the future of that area as sort of real in-depth research onto the nitty-gritty of aligners in terms of thickness and all those sort of things. That's sort of the next step and probably along with printing them in-house, right? Being able to control a little more and printing them in orthodontic offices.
I think you have that paper coming out very soon by Dr. Nisko, because he has been printing in his office for the last 10 years. And I think that would be a very nice paper for JCO.
Yeah, well, we've obviously, we have the aligner corner as part of JCO, and that was something we started a few years ago. And we did a special issue on it in January. And, we're, as we said in Dr. Kime's kind of thing on Friday that he did, that was called the cutting edge. We try to stay on the cutting edge, which sometimes means that we do veer over, right? That's what happens on the cutting edge. You do sometimes do things that don't necessarily pan out later. But yeah, I mean, the modern orthodontic office is going to be, even in 5 years, is going to be very different than it is now.
And I must say here that JCO, the journal, has played a critical role in the practice of orthodontics. I mean, we all like higher impact journals, but those are basically research related articles which sort of enhance our general knowledge, or basic knowledge about orthodontics. But the day-to-day things which people do in their practice, JCO is fantastic. And I've never believed that the case reports are the bottom of evidence base, because because case reports are basically telling people that if you do this, you can do it right. If you do this, you may have issue problems. And I've always said that people always ask me, Dr. Nanda, I mean, why do you publish case reports? Well, case reports we publish because we are showing people biomechanics. Biomechanics is not going to change. I always give example that Newton didn't have to sit there and see about 100 apples fall to decide,
Right.
oh, gee, really there is a gravitational force, you know. So case reports, biomechanics, it works in one case, it's going to work in every case after that. You know, this is the example I always give about JCO, you know.
Yeah.
So I always say every orthodontist should have this journal on their table once a month, new one.
Yeah, well, that's a great way to stop. We're out of time. I will definitely steal the Isaac Newton anecdote because that works perfectly for us. But as I said at the beginning, we did record this. I will have it up later this afternoon on all our platforms. It'll be available in our booth and everything. But I want to thank Dr. Nanda for taking the time out to
Thank you,
chat
Phil.
with us.